Hello everyone, my name is Chisa Mamadi and today I will be discussing two cases from this unit, focusing on metabolic disorders. So I've chosen case 2, which involves a 16-year-old female diagnosed with muscle glycogen phosphorylase deficiency, and case 4, which involves a 2-month-old female presenting with hypoglycemia and hepatomegaly. So let's start with case 2, muscle glycogen phosphorylase deficiency. This case involves a 16-year-old female recently diagnosed with a deficiency in muscle glycogen phosphorylase. Her family is understandably concerned, and they have a few questions that I will be addressing. So their first question is, how is muscle glycogen normally used during exercise? During exercise, your muscles need a lot of energy quickly. Normally, this energy comes from glycogen, a stored form of sugar in your muscles. The glycogen is broken down by an enzyme called glycogen phosphorylase into a form of sugar that your muscles can use right away for energy. Muscle glycogen is crucial for energy production during exercise. In a normal scenario, glycogen stored in the muscles is broken down into glucose 1-phosphate by the enzymes glycogen phosphorylate. This glucose 1-phosphate is then converted into glucose 6-phosphate, which enters the glycolytic pathway to produce ATP, which is what our cells need for energy. During high-intensity exercise, the demand for ATP increases significantly, and glycolysis speeds up to meet this demand. Their next question to me was, will she be able to take long walks with her friends still? Yes, she should be able to still enjoy long walks with her friends. Walking is a lower intensity exercise, so the body can use other sources of energy, like fats and sugars from your blood, instead of relying heavily on muscle glycogen. With muscle glycogen phosphorylase deficiency, patients can usually manage lower intensity exercises because these activities rely more on aerobic metabolism and less on glycogen breakdown. During low intensity exercise, the body usually just uses fatty acids and blood glucose for energy, so this reduces reliance on muscle glycogen. The next question they had for me was, will she need to get up at night to eat to maintain her blood glucose levels? No, she does not need to get up at night to eat. This condition affects the muscle's abilities to use stored glycogen during exercise, but doesn't impact your blood sugar levels, which are regulated by your liver. The deficiency primarily affects muscle glycogen, not liver glycogen. The liver plays an important role in maintaining blood glucose levels, specifically during fasting, so while you're asleep. Therefore, this condition does not affect the liver's ability to regulate blood glucose, and there is no need for additional nighttime feeding. And here I have a picture depicting that. The next question her family had for me was, will she produce excessive lactate during intense anaerobic exercise? She doesn't need to worry about producing too much lactate during intense exercise. Since the muscles can't break down glycogen properly, they won't produce as much lactate. However, she might experience muscle fatigue sooner because the muscles won't have enough energy. Without functional glycogen phosphorylase, muscles can't efficiently break down glycogen into glucose 6-phosphate, which limits the substrate available for glycolysis and consequently reduces lactate production. However, muscle fatigue may occur more quickly due to the lack of readily available energy. Now let's move on to case 4. For case 4, we're discussing the diagnosis of hypoglycemia in an infant. This involves a 2-month-old female who presents with jittery spells hours after being breastfed. Her mother reports these symptoms started when the baby began sleeping for more than 2 hours between feedings. Her lab results show hypoglycemia with an otherwise relatively normal profile. The key points to consider here are the response to epinephrine and the presence of hepatomegaly. Now, let's go through some of these possible diagnoses and talk about why they are incorrect. First, we have hereditary fructose intolerance. This condition presents symptoms upon ingestion of fructose-containing foods, like nausea, vomiting, and jaundice, and not exclusively hypoglycemia. So we can rule that one out. Galactosemia. This would cause symptoms upon ingestions of galactose, which is found in milk, leading to jaundice and other problems like refusal to eat, vomiting, sepsis, and other symptoms, not just hypoglycemia and hepatology. And it doesn't say anywhere in the labs that the infant was experiencing any of these other symptoms besides the hypoglycemia and hepatology. So we can rule that out as well. We have glucose 6-phosphate dehydrogenase deficiency. This typically presents with hemolytic anemia due to oxidative stress, enlarged spleen, jaundice, and paleness, not hepatomegaly or isolated hypoglycemia. So we can rule that out as well. So the final diagnosis we would have, based on the symptoms and the lab results, would appear to be glycogen storage disease. This condition affects the body's ability to break down stored glycogen into glucose, which is why her blood sugar levels drop between feedings and why her liver may be enlarged. So let's talk about the epinephrine response. Epinephrine stimulates glycogenolysis and gluconeogenesis, raising blood glucose levels. In this case, epinephrine administration increased blood lactate, but not the blood glucose. So this indicates a block in the glycogenolysis or the gluconeogenesis. So for the hepatomegaly symptom or enlarged liver, due to the accumulation of glycogen, a hallmark of GSD or glycogen storage disease. Her symptoms and feeding response. The infant's hypoglycemia is alleviated by feeding, which indicates the issue lies with glycogen storage and mobilization rather than with glucose intake or absorption. In conclusion, these cases highlight the importance of understanding metabolic pathways and their clinical implications. Case 2 emphasizes how muscle glycogen phosphorylase deficiency affects energy metabolism during exercise. Case 4 shows the diagnostic process for hypoglycemia in infants, leading to the identification of glycogen storage disease. Understanding these conditions help in managing the symptoms and providing appropriate care for the patients. Thank you for watching my presentation. I hope this has provided a clear understanding of the metabolic disorders discussed in these cases.